Thanks very much for having me. So you've got the background. So I'm an orthopaedic surgeon, but these days I'm more a researcher than a surgeon, although I still do both. And my area of interest is surgical outcomes, and my thesis was actually on outcomes in the compensation environment. So I want to show you a little bit about my personal experience and throw some numbers and examples at you, my take on outcomes. So we know what's commonly measured, it's process outcomes, it's things that are easily measured and more or less subjective outcomes, and particularly things contained in administrative data sets. But there's problems with this. And now this is a small area of research I did 2007 or so, where we just wanted to look at the outcomes of spine surgery in the New South Wales workers' comp environment. So we went in there, said, give us a list of all your patients who had spine surgery. We're going to look at the costs related to that, their return to work, how many of them were having ongoing treatment 2 years later, etc. And they said, okay, here's all our data. They had no record at that time of who, with a back injury claim, had had surgery. There was no way of telling whether somebody had had surgery or not. It was not recorded. So in order to determine it, we had to cross a back injury with a hospital costs of greater than $2,000. And then we had to search the files, because sometimes people with a back injury ended up having a shoulder operation later on. So there's actually no way of finding out who had surgery. So this is the kind of problems we have with the data. And I'm just going to quickly echo one of Neil's points, is we can look at all of the available data on prostate cancer, and we can look at patients who present to a state or a territory in Australia and say, what's the screening rate? How long do people wait before they're screened to when they get a biopsy? If they get a biopsy, do they get their surgery in a short period of time? What's the waiting time? We all know what the waiting time is, down to the last day in every state. How long are they in hospital for? Are we wasting time with them in hospital? And we can get all of this data. We can even get mortality afterwards. And so we can find out whether we're doing really well in prostate cancer. The problem is that until recently, because the rates have been falling so much of prostatectomy, certainly about 10 years ago, most of the prostatectomies done were not helping anybody. And in most of the cases, they were leading to incontinence and impotence, which people didn't like. So we were decreasing the quality of life and not altering mortality. So that's what we're actually doing, but this is what we're measuring, and everything's really good because they're getting the surgery done on time, they're getting home early. So it's just a good example of maybe where the focus should be. So what should we be measuring? We should be measuring what we're trying to achieve. And what we're trying to achieve is improve patient health largely, but there's areas of safety and effectiveness, and certainly there's some process measures we're trying to measure as well because we're interested in costs. But patient health is what the whole thing is all about. There's no point lowering or raising the cost if it doesn't achieve that. As an example, this is the Australian New Zealand Hip Fracture Registry, and we set this up in 2012, and we set it up in a way where we want to measure the performance of how people are being cared for with a hip fracture, because it's not being measured now. Well, it is now, it wasn't then. And so what we did is we said, okay, we need to develop some guidelines. That last slide is guidelines which we produced in 2014. We went through all of the evidence and produced the highest quality evidence-based guidelines we could of how to manage people with a hip fracture. We then went to the Commission on Safety and Quality and the equivalent commission in New Zealand. They got together and said, we're going to develop hip care standards, hip fracture care standards. And we produced this book in 2016, which has 7 standards in it. This is what you have to do in order to treat people with hip fractures properly. And this is just an example, and each of them comes with indicators that you can measure to tell if you're actually doing a good job. And then we set up a registry to measure all of this. And this is just a snapshot from our hospital. So this is a snapshot from the registry annual report showing you variation. Each one of those little lines on the bottom is a hospital, a named hospital in Australia, and this is the proportion of cases that are mobilised on day one. It's very important to get people mobilising day one, or else they're more likely to get complications and stay in hospital longer, etc. And this shows you the variation, and the whole book's full of this sort of variation. The top lines are changes over years from 2015 to 2018. And this is an example of what you can get live data from our hospital, showing you each of the 7 indicators and how we're going. And these are largely not measured in administrative data sets. Time to surgery maybe, but Did they get a cognitive assessment when they presented? Did they get a nerve block when they were in the emergency department? Were they seen by an orthogeriatrician? None of that is in administrative data sets, and that's what counts. Another problem I had was a few years back, I tried to do some research looking at the need for a knee replacement after having a knee arthroscopy. Pretty straightforward stuff. Got all the administrative data. We've got all the people who had knee arthroscopies, and we want to find out if they had a replacement afterwards. We can link them all. The problem is there's no data in any statewide hospital data set that has laterality. Left or right is not included. It never has been. I've been fighting for it my whole academic career, and no one has added it. It's not possible to tell whether somebody perhaps had a left knee arthroscopy and then a right knee replacement later. It's not recorded anywhere in the administrative data. It's completely useless to do research on. Why are we researching the arthroscopy? This goes to the other thing about effectiveness. Here's some trials that are all published in the New England Journal of Medicine showing that knee arthroscopy is ineffective with degenerative conditions of the knee, which is largely why knee arthroscopies are done. It's one of the most common surgical procedures performed in the world. It is probably the most common orthopedic procedure performed in the world. Multiple guidelines have been published showing that it's ineffective. Further research is unlikely to change this conclusion. And yet these are the variations we get in Australia. You saw a similar example before. There's about a 7-fold variation. If you look at the lowest rates, that's southwest Sydney, and it's fallen further since then. So we have actually been able to change practice. So data can change practice. But it wasn't administrative data that changed practice, it was research data. So there's about a 48% fall in New South Wales in knee arthroscopy rates in people over 50 since 2011. But a lot of people, even in the medical world, in registries and things like that, measure improvement. They say, we just want to measure how effective it is by seeing how much people improve. That's not really a valid measure. If you look at health improvement post-surgery, most people improve post-surgery, but they don't necessarily improve because of the surgery. It's this post hoc ergo propter hoc. It follows, therefore it is because of. Most people with a knee arthroscopy, who get a knee arthroscopy, have arthritis. They've got a sore knee. It's sore one day, it's okay the next, it's bad for a week, it's good for a month, it's bad for 2 months. It's up and down all over the place. Sometimes it's really bad. If you go and see a doctor and have an arthroscopy when it's really bad, what's going to happen afterwards? It's not going to be really bad again. It wouldn't have anyway. But we attribute the improvement to surgery. And that's why you need a comparator. And that's why you need the research to inform you. And this is taken from the placebo surgery study where they compared knee arthroscopy and meniscectomy to pretend arthroscopy and meniscectomy. All patients were blinded, no difference between the two groups whatsoever. This is variation in the use of inpatient rehabilitation. Now, it costs $20,000 for every knee replacement we do in Australia. It costs another $10,000 for inpatient rehabilitation. And the variation between surgeons goes from 100% of their cases go to inpatient rehab to 0% for many surgeons. We've published randomized trials, systematic reviews showing that it is completely ineffective. It adds nothing but cost. It adds not 1 degree of range of motion or patient satisfaction, and yet the range of surgeons using this is 100% to 0%. This is the kind of thing we should be measuring. So this goes to healthcare waste. This is a recent publication. The estimated cost of waste in the US range from $760 to nearly $1 trillion, about 25% of healthcare spending. So just in wrapping up, we can measure all of these things, and this is one of our registry outputs showing pre-operative and post-operative hip scores, hip pain and function scores for people undergoing hip replacement, showing that most of them are poor beforehand, they go to excellent afterwards. This is really good. But it doesn't tell us, that's hip replacement, similar for knee replacement, but it doesn't tell us whether we should be doing it or not. Because this graph, which only came out last week, this is the OECD data, shows that Australia has one of the highest rates of knee replacement in the world. So we're doing a lot of unnecessary surgery. So in summary, there is a disconnect between what health planners and payers read as their outcomes and patient-relevant and society-relevant outcomes from the money we spend. And there's a lot of waste, harm, and ineffective treatments But this is largely unaddressed and unmeasured. Thanks.